Welcome to the Radiographics Podcast. I'm Wende Gibbs. This week, Dr. Frederick will give us a summary of a classic, very important article for trainees on call, really a good refresher for all of us, Radiologic Clues to Cerebral Venous Thrombosis. And I'll discuss imaging safety for pregnant patients, including modalities and contrast use. This is a question that does come up for residents, fellows, radiologists in practice. How can we most safely image a patient who's pregnant? In this article, Imaging Cancer in Pregnancy, the authors are focused on pregnancy-associated cancer, which is defined as cancer detected during pregnancy and up to 1 year postpartum. The first section of the paper is focused on selection and safe use of imaging during pregnancy, and this is the aspect of the paper I'll focus on in the summary. But for pregnancy-associated cancer, it's rare, about 1 in 1,000 pregnancies, but this is increasing, possibly due to postponed childbearing and advanced maternal age at conception. Cancer-related symptoms are masked by physiologic gestational changes and may delay diagnosis. Imaging, clinical management, and treatment require a multidisciplinary team approach. The risk-benefit of every imaging modality, the strategies to balance the safety of mother and fetus, and the support of the patient and family at every step are crucial. Ultrasound and MRI are preferred imaging modalities that lack ionizing radiation. But for those with radiation concerns, most imaging exams, including mammography, radiography, CT, and sulfur colloid sentinel lymph node staging, are performed at radiation levels below thresholds at which deterministic side effects are seen. So remember that a deterministic effect is a health effect that requires a specific level of exposure to ionizing radiation before it can occur. The severity of deterministic effect increases as the dose of exposure increases and has a minimum threshold below which no detectable clinical effects occur. This type of effect is predictable and reproducible. For example, localized doses to certain parts of the body at increasing levels will result in the same biological effects. These include tissue reactions like hair loss, cataracts, skin injury, etc. This is in contrast to stochastic effects, like cancer, which are all or nothing with no minimum, based on modeling. Dose estimates should be provided after each exam. The use of iodinated intravenous contrast is safe during pregnancy, but gadolinium-based contrast material should be avoided. Accurate diagnosis and staging, combined with gestational age, affects decisions about surgery and chemotherapy. The authors provide an update of the imaging triage, safety considerations, cancer-specific imaging, and treatment options for cancer in pregnancy. Ionizing radiation and teratogenesis. This is the part that all radiologists and those learning should know, as pregnant patients may need to be imaged for reasons other than cancer, and all may be asked to advise the ordering physicians. CT exposes the fetus to ionizing radiation. The radiation dose and projected cumulative fetal dose should be limited to below the threshold of 0.10 gray, or 10 rads, to adhere to the as low as reasonably achievable, or ALARA principles. Radiography or CT exams that do not include the uterus have negligible fetal exposure. CT of the head, neck, thorax, and extremities is generally considered safe. Dose-related deterministic effects, as extrapolated from nuclear bomb exposure in experimental studies, are related to radiation exposures above thresholds that cause cellular death, pregnancy loss, fetal malformations, fetal growth restriction, and mental retardation. Since most diagnostic imaging studies are below the 0.10 gray, or less than 10 rads threshold dose for deterministic effects, a single imaging exposure usually does not warrant concern. Even when the gravid uterus is included in the field, the typical dose from a single pelvic CT exam is less than 0.05 gray, or 5 rads, with no known deterministic fetal health effects. The risk of injury from ionizing radiation depends on fetal gestational age and decreases with advancing gestational age. Based on animal studies, exposure during the pre-implantation stage is an all-or-nothing phenomenon. Between 4 and 10 weeks gestational age, the embryo is susceptible to teratogenic effects. After 10 weeks, the main reported risks were fetal growth restriction and mental impairment. The most vulnerable period for intellectual disability is 8 to 15 weeks, with potentially severe intellectual disability at doses greater than 0.5 gray or 50 rads. Exposure to higher doses, greater than 0.5 gray, during the first or second trimesters can lead to fetal malformations, neurologic and motor deficits, and malignancy. Stochastic effects are extrapolated from epidemiological studies and may occur after any level of exposure with a variable timeline. They may lead to radiation-induced cancers, typically childhood leukemias. A fetal dose of 0.1 gray carries a small individual risk of radiation-induced cancer. More than 99% of exposed fetuses will not develop a childhood cancer or leukemia. Imaging options and contrast material administration. Counseling and informed consent for imaging during pregnancy with ionizing radiation or use of contrast should include a radiation dose estimate to the mother and fetus, an explanation of the potential risks, discussion of the expected benefits, and response to questions or concerns. Templates for consent are provided by the American College of Radiology. If administration of gadolinium-based contrast material is recommended based on patient-centered multidisciplinary discussion, then well-documented consent with risk-benefit analysis is advisable. Ultrasound has an excellent safety profile for obstetric and non-obstetric indications and lacks ionizing radiation. Most patients will undergo ultrasound in routine prenatal care. Although no known detrimental effects have been documented in human fetuses, there is a theoretical risk of tissue heating and cavitation from insemination. Obstetric ultrasound should not exceed the recommended limits of thermal and mechanical indices. Ultrasound contrast materials are not yet US FDA approved in pregnancy. How about MRI? With its superior soft tissue contrast resolution, multiplanar capability, and lack of ionizing radiation, it's optimal for imaging during pregnancy. Both 1.5 and 3 Tesla MRI systems can be used for imaging in pregnancy without reported evidence of harm to the fetus in the medical literature. Not mentioned in this particular paper is the concern for energy deposition. Fetal heating greater than 2 degrees Celsius has been reported to be teratogenic. Fetal SAR cannot be measured directly, but must be estimated from the mother. Models have shown that the fetus receives approximately 40 to 70% of the maternal SAR. While there is concern for fetal acoustic injury, noise at 3 Tesla MRI has not been associated with clinically detectable hearing abnormalities. The American Academy of Pediatrics recommends a limit of 90 decibels or less for fetal sound exposure. Thus, sequences that are associated with acoustic noise of up to 120 decibels, such as 3D fast gradient echo, should be eliminated or shortened. How about contrast-enhanced MR? Gadolinium is a pregnancy Category C drug with adverse effects reported in animal studies. Only gadolinium-based contrast materials that are considered low risk for development of nephrogenic systemic fibrosis should be used, and only at the lowest doses to obtain diagnostic results. Gadolinium crosses the human placenta with a theoretical risk of accumulating in amniotic fluid and associating into free gadolinium ions that are known to be more harmful than the chelate. According to the authors, a large retrospective study of contrast-enhanced MRI examinations in the first trimester showed an increased but rare occurrence of rheumatologic, inflammatory, or infiltrative skin conditions in exposed fetuses. When possible, diffusion-weighted imaging can serve as an alternative to gadolinium-based contrast material, and non-contrast black blood imaging sequences can be performed to assess vascular structures. I want to include here the ACR 2020 recommendations, which are not in this article. Recommendations for the use of gadolinium-enhanced MRI exams in pregnant patients. Because it's unclear how gadolinium will affect the fetus, these agents should be administered with caution to pregnant or potentially pregnant patients. Gadolinium should be used only if the usage is considered critical and the potential benefits justify the potential unknown risk to the fetus. If a gadolinium-based contrast agent is to be used in a pregnant patient, one of the agents believed to be at low risk for development of NSF should be used at the lowest possible dose to achieve diagnostic results. In pregnant patients with severely impaired renal function, the same precautions should be observed as in non-pregnant patients. The ACR Committee on Drugs and Contrast Media recommends the following concerning the performance of contrast-enhanced MRI exams in pregnant patients. Each case should be reviewed carefully by members of the clinical and radiology service groups, and a gadolinium-based agent should be administered only when there is a potential significant benefit for the patient or fetus that outweighs the possible or unknown risk of fetal exposure to free gadolinium ions. The radiologist should confer with the referring physician and document the following in the radiology report or the patient's medical record: that information requested from the MRI study cannot be acquired without the use of IV contrast or by using other imaging modalities, that the information needed affects the care of the patient and/or fetus during pregnancy, and that the referring physician is of the opinion that it is not prudent to wait to obtain this information until after the patient is no longer pregnant. Next, it's recommended that informed consent be obtained from the patient after discussion with the referring physician. So if I'm understanding the wording correctly, the ACR is saying we discuss with the ordering physician, and it's the ordering physician, not us, that should be getting information and consent from the patient. So that's interesting. Probably we should all do it together. How about breastfeeding? A small amount of gadolinium is excreted in human breast milk, about less than 0.04% of the intravascular dose within the first 24 hours. Because less than 1% of the ingested amount is absorbed by the infant's GI tract, the absorbed dose in an infant is negligible. The ACR suggests that it's safe to continue breastfeeding after maternal administration of IV gadolinium. Now let's go back to CT. CT with ionizing radiation may be necessary in pregnancy for life-threatening conditions such as trauma or suspected pulmonary embolism. Abdominal shielding is not recommended during pregnancy because the majority of the dose to the uterus and fetus is from internal scatter. Use of low-dose CT in pregnancy has been described in acute conditions such as appendicitis or renal colic, and for CT pelvimetry. Literature on low-dose CT for malignancy workup in pregnancy is scarce, but it may be considered if MRI is contraindicated. While iodinated intravenous contrast material improves evaluation of soft tissues and vascular structures, it does cross the placenta and enters the fetal bloodstream. Once excreted through fetal urine into the amniotic fluid, the contrast material may be swallowed by the fetus and enter the GI system. The ACR manual on contrast media reports no known teratogenic or mutagenic effects in animal studies from low osmolality contrast material. However, there are no well-controlled trials in human fetuses. Additionally, maternal iodinated contrast administration has not been found to affect short-term neonatal thyroid-stimulating hormone, but the long-term effects of fetal exposure are unknown. Oral iodinated contrast material remains in the maternal GI tract and is considered safe for administration during pregnancy. Postnatally, iodinated contrast administered to breastfeeding patients has been associated with minimal fetal exposure. Only a small amount of contrast material is excreted into the breast milk in the first 24 hours. Given its low lipid solubility and minimal absorption by the neonatal GI tract, both reported as less than 1% of the administered maternal dose, iodinated contrast results in an expected systemic dose to the infant of less than 0.01% of the IV dose. Therefore, toxicity and allergic effects of ingested iodinated contrast material excreted in the breast milk are negligible, and breastfeeding can be continued. Nuclear medicine. When radiopharmaceuticals are administered to the mother, radiation exposure to the fetus occurs as radiotracer accumulates in the maternal organs, as well as from transport or diffusion across the placenta. Several radioisotopes are considered unsafe in pregnancy. For example, I-131 crosses the placenta and remains in the fetus for days, potentially injuring the fetal thyroid, particularly after 10 to 12 weeks of gestation. Therapeutic radiopharmaceuticals generally should not be administered during pregnancy unless there's a life-threatening maternal condition, which in turn might prompt consideration of pregnancy termination after fetal dose and gestational age are calculated. Breastfeeding after radiopharmaceutical administration depends on the agent and administered dose, as variable amounts may be excreted in breast milk. Depending on the biologic properties, such as the half-life, nursing recommendations range from no or short interval interruption to permanent cessation. FDG is unique in that it's not excreted in breast milk, but infants should not be held close to the mother's breast for at least 12 hours owing to the accumulation of radioactivity within the breast tissue. Take a look at this article to learn more about pregnancy-associated cancer, but also make sure you know the most current recommendations regarding contrast administration, ionizing radiation, and the effects on mother and fetus. Okay, let's switch gears and hear from Ross Frederick about the vital and often difficult diagnosis of cerebral venous thrombosis.
Radiologic clues to cerebral venous thrombosis. Cerebral venous thrombosis is an uncommon condition that is potentially reversible if it is diagnosed and treated appropriately and promptly. Cerebral venous thrombosis can occur at any age, although it is more common in neonates and young adults 20 to 40 years old. It is also more common in women because pregnancy, postpartum status, and the use of oral contraceptives increase the risk of thrombosis. Diagnosis is difficult because the clinical manifestations are nonspecific, such as headache, seizures, altered consciousness, and focal neurologic deficits. For this reason, imaging is crucial to diagnosis, and radiologists must be able to identify the findings that raise suspicion of cerebral venous thrombosis so that appropriate treatment can be started early to avoid complications and even death. It is one of the only causes of cerebral hemorrhage that calls for anticoagulation therapy. Since anticoagulation is contraindicated in most cases of cerebral bleeding, diagnostic certainty is important, making the radiologist's task more difficult. In venous occlusion, changes in the brain parenchyma can develop secondary to vasogenic edema, cytotoxic edema, or intracranial hemorrhage, giving rise to two possible scenarios: venous thrombosis with local effects and venous thrombosis with increased intracranial pressure. Thrombosis leads to the formation of an area of focal cerebral edema because of increased retrograde pressure, which is characterized by dilated veins, petechial hemorrhages that can converge and give rise to larger hematomas, and ischemic neuronal damage. Thus, two types of edema can develop: vasogenic and cytotoxic. Dural sinus thrombosis obstructs venous drainage, leading to increased blood pressure due to delayed venous emptying and decreased absorption of cerebrospinal fluid. First, there is an increase in retrograde venous pressure with venous congestion and drainage through the collateral vessels. If the collateral vessel circulation is good, the only symptoms are those related to intracranial hypertension. However, if the collateral vessel circulation is inadequate or the thrombosis extends to the cortical veins, intracranial pressure continues to increase to the point at which the cerebral perfusion pressure decreases, which could give rise to ischemic damage and cytotoxic edema. There are several subtypes of cerebral venous thrombosis: dural, deep, and isolated cortical venous thrombosis. Let's start with dural sinus thrombosis. Dural sinus thrombosis has multiple risk factors and predisposing conditions, including local causes such as head trauma, where venous thrombosis usually is associated with skull fractures that extend to the dural sinus or the jugular bulb. Additional local causes include brain tumors or local infections. Systemic causes include hormonal imbalance, surgery, hematologic disease, systemic infections, and dehydration. In general, non-enhanced CT of the head is the first-line imaging exam in patients who present to the ED with neurologic symptoms. However, the direct visualization of thrombosis as hyperattenuation in the occluded sinus is not very sensitive and is present in less than half of cases. This increased attenuation coefficient in the sinus is caused by a decrease in the amount of serum and an increase in the amount of fibrinogen and proteins in the thrombus. This finding is seen only in acute and subacute cases because the thrombosis becomes isoattenuating after 2 weeks. Giving IV contrast, as in CT venography, makes it possible to identify a filling defect in the occluded dural sinus. Contrast is injected after a 45 or 50 second pre-imaging delay. Caution must be taken to achieve a well-timed acquisition, and particularly in cases of intracranial hypertension, which can cause delayed filling of the venous sinus, thus simulating sinus thrombosis. The empty delta sign consists of a triangular area of contrast that surrounds a hypoattenuating area and represents the thrombus. The empty delta sign is seen in 1/3 of cases and may be absent in the acute phases of the process, in which the thrombus is hyperattenuating, mimicking a pacification of the sinus, and in the chronic phases, in which the thrombus can contain recanalization channels. Other imaging findings that can develop secondary to increased retrograde pressure and should raise suspicion of venous thrombosis include venous ectasia, prominent medullary veins, and enhancement of the falx and tentorium. Non-enhanced MRI is more sensitive than non-enhanced CT for detecting thrombus. Blood flow in the dural sinuses is seen as a flow void, especially on T2-weighted and flare sequences. For this reason, when there is an absence of flow void or altered signal intensity in the dural sinus, the possibility of venous thrombosis must be investigated, although slow or turbulent flow can also mimic thrombosis. One of the main difficulties in evaluating venous thrombosis with MRI is the variation in the signal intensity of the thrombus depending on its age. This phenomenon is due to the paramagnetic effects of hemoglobin degradation products. Usually, acute thrombosis, 1 to 5 days, is T1 isointense and T2 hypointense due to deoxyhemoglobin. Subacute venous thrombosis, 6 to 15 days, is both T1 and T2 hyperintense due to methemoglobin. And chronic thrombosis greater than 15 days is T1 isointense and iso to hyperintense on T2 weighted images. However, the use of T2 star weighted GRE and susceptibility weighted sequences improves the detection of acute phase thrombosis because the magnetic susceptibility of deoxyhemoglobin makes dural sinus thrombosis hypointense. 2D time of flight and 3D phase contrast MR venography are non-enhanced venography techniques that show the absence of normal signal intensity in sinus thrombosis. These are key methods when contrast agents are contraindicated. The 2D time of flight sequence is based on the inflow effect, and it is performed with sections that are perpendicular to the direction of the blood flow. This sequence is highly susceptible to flow artifacts and is dependent on the acquisition plane. A sinus parallel to the acquisition plane may have an artifactual signal intensity loss that mimics venous thrombosis. Furthermore, stationary tissue with short T1, such as fat or methemoglobin, may be mistaken for flowing blood. Another disadvantage of this technique is its reduced sensitivity for small vessels with slow flow. On the other hand, 3D phase contrast MR venography is based on the dephasing of moving spins submitted to a bipolar gradient in GRE acquisitions and has better sensitivity to slow flow than does 2D time of flight and is less affected by tissue with short T1 values. However, with this technique, long acquisition times are required and aliasing artifacts can occur. Contrast-enhanced MR and CT venography are the best techniques for detecting venous thrombosis, and MR venography is the technique of choice for assessing recanalization after treatment. When recanalization is incomplete, the appearance of the sinus at MR venography is irregular, with residual defects in the lumen of the venous sinus, channels in the sinus, and collateral dural vessels. Associated abnormalities in the brain parenchyma are present in half of cases and are located in subcortical territories that are not in the typical arterial vascular distribution. Changes in the parenchyma may be located near the drainage of the involved sinus. However, in some cases, parenchymal changes do not correlate with the site of venous occlusion. Bilateral parasagittal hemispheric lesions suggest thrombosis of the superior sagittal sinus. Temporooccipital lesions and lesions of the ipsilateral cerebellar lobe can be seen in patients with transverse sinus thrombosis. The most commonly observed findings in the parenchyma are vasogenic and cytotoxic edema, which can coexist, as well as intraparenchymal hemorrhage. Vasogenic edema develops secondary to elevated retrograde venous pressure. Parenchymal hemorrhage is observed in 1/3 of cases, typically in the cortex and extending subcortically. Let's touch on some pitfalls. On non-enhanced CT, increased attenuation of the dural sinuses can be seen in the absence of venous thrombosis in patients who are dehydrated, have high hematocrit values, or have subarachnoid or subdural hemorrhages. To differentiate between a physiologic increase in attenuation and attenuation caused by venous thrombosis, it is important to compare the attenuation of the venous sinuses and that of the arteries in both sides, because in cases of physiologic increase, the arteries are also hyperattenuating. Normal structures and normal variants can give rise to findings similar to those reported in venous thrombosis. The transverse sinuses are asymmetric in 85% of cases. Hypoplasia and/or atresia of the transverse sinuses occur frequently and may mimic a lack of flow in the sinus on non-enhanced MR venography. This is why using contrast is better. Arachnoid granulations are normal structures that protrude into the lumen of the venous sinuses, which can therefore be mistaken for filling defects. However, their typical location in the transverse sinuses, particularly within the middle and lateral portions, and their characteristic rounded shape and signal intensity, or attenuation similar to that of cerebral spinal fluid at MRI, help to avoid confusion. Let's touch on cavernous sinus thrombosis. Imaging features include asymmetrically decreased enhancement and lateral bulging of the affected sinus. Indirect signs of cavernous sinus thrombosis are dilatation of the superior and inferior ophthalmic veins, intraorbital fat stranding due to venous congestion, exophthalmos, and increased dural enhancement along the lateral border of the cavernous sinus and ipsilateral tentorium. Let's move on to deep cerebral venous thrombosis. The deep venous system includes the internal cerebral veins, which course through the roof of the third ventricle, joining the basal veins of Rosenthal to form the vein of Galen, which in turn joins the inferior sagittal sinus to form the straight sinus. On non-enhanced MRI, the characteristic finding for deep cerebral venous thrombosis is bilateral thalamic edema, which can be cytotoxic or vasogenic, which is present in the vast majority of patients. This edema may extend to the basal ganglia and to the adjacent deep white matter. Moreover, bilateral thalamic edema can compress the foramina of Monro or the third ventricle and cause hydrocephalus. Hemorrhagic transformation, typically in the thalami, is seen in 20% of patients. MR venography and susceptibility-weighted MRI sequences should be used to confirm the diagnosis whenever bilateral thalamic edema is observed. The differential diagnosis of bilateral thalamic lesions and deep venous thrombosis includes evaluation for vascular lesions, infections, toxic or metabolic disorders, and tumors. The thalamus receives its blood supply from both the anterior and posterior circulation. An occlusion of the distal tip of the basilar artery could give rise to bilateral thalamic infarction from occlusion of the paramedian perforating branches. Likewise, an occlusion of the artery of Percheron, a rare variant in which a single arterial trunk supplying the thalamus originates in the P1 segment of one of the PCAs, could also explain abnormalities in both thalami. Therefore, in these cases, the arterial system must be evaluated to confirm the occlusion. Unlike venous infarction, which usually occurs more centrally in the thalamus, arterial infarction normally occurs in the paramedian areas and has homogeneous diffusion restriction and little swelling. In addition, in deep venous thrombosis, when hemorrhagic transformation is present, it tends to extend from the center toward the periphery, whereas in arterial infarction, it tends to spread from the periphery to the center. Let's discuss isolated cortical vein thrombosis. In the superficial venous system, cortical veins drain blood from the cerebral cortex and the subcortical white matter toward the dural sinuses rather than into the deep venous system. Isolated cortical vein thrombosis is difficult to diagnose because the cortical veins are small and peripheral. Often, only indirect signs can raise suspicion, such as edema or focal cortical hemorrhage, prominent collateral veins, or congestion of adjacent veins. Non-enhanced CT shows the cord sign, a well-defined hyperattenuating linear structure in a cerebral sulcus corresponding to the thrombosed vein. An area of edema or focal cortical or subcortical hemorrhage near the thrombosed vein is present in most patients with isolated cortical vein thrombosis. Therefore, when edema or focal hemorrhage is detected, it is important to evaluate the attenuation and signal intensity of the adjacent cortical veins, especially when these lesions are not in an arterial distribution. Alright, now let's recap a few key points. Although most patients with cerebral venous thrombosis have more than one risk factor, up to 20% of cases are idiopathic, so the absence of risk factors does not rule out the diagnosis. The empty delta sign consists of a triangular area of enhancement that surrounds a hypoattenuating area and represents the thrombus. Although this sign classically is found in the superior sagittal sinus, a similar sign can be seen on sagittal and coronal images of the transverse sinus. The most commonly observed findings in the parenchyma are vasogenic and cytotoxic edema, which can coexist, as well as intraparenchymal hemorrhage. On non-enhanced MRI, the characteristic finding for deep cerebral venous thrombosis is bilateral thalamic edema. This edema may extend to the basal ganglia and to the adjacent deep white matter. When edema or cortical or subcortical focal hemorrhage is detected, It is important to evaluate the attenuation and/or signal intensity of the adjacent cortical veins, especially when these lesions are not in an arterial distribution.
That was great. I always want to review that subject. It can be really difficult, and missing it can be catastrophic. As always, take a look at these articles in the print journal or online, where you can also find related resources, and look for cases and summaries on Twitter. Thanks for listening. We'll be back in 2 weeks with more summaries.